We all want to feel safe, right?
Yeah,
Especially when we're in a hospital. You want confidence in the care.
absolutely. But healthcare is, well, incredibly complex these days.
It really is. So how do we actually know
Mm-hmm.
if a hospital is, ensuring quality care? What's the benchmark?
That's a great question, and that's what we're digging into today.
Okay, let's unpack this because for this deep dive, we're going straight to the source. We're looking at the standards hospitals actually aim for.
Exactly. Standards designed to show their commitment to quality and safety. Our main guide here is the 6th edition of the NABH accreditation standards for hospitals.
NABH, National Accreditation Board for Hospitals and Healthcare Providers.
That's the one. This edition just came out January 2025, so fresh guidance.
And NABH, they've been around for a while, haven't they? Almost, 19 years now?
Yeah, nearly 2 decades. They've played a pretty big role in pushing for quality, safety, and that continuous improvement mindset in Indian healthcare.
So our mission today really is to get a handle on what's in these standards, what are the key bits?
And crucially, what they mean for you, for the patient, for the care you might actually receive.
Right, because these standards, they cover a lot of ground, don't they?
Oh, absolutely. They leave no stone unturned. We're talking everything from patient rights and education PRE.
Making sure you know what's going on and you're involved.
Exactly. To the really critical stuff like infection prevention and control, IPC. Hugely important.
Couldn't agree more. What else?
Then there's patient safety and quality improvement, PSQ. The responsibility of management, ROM, making sure leadership is focused on this.
That makes sense. It has to come from the top.
Definitely. Plus, facility management and safety, FMS, the building itself, the environment, human resource management, HRM, the staff.
Making sure they're qualified and trained.
Precisely. And even the information management system, IMS, how your records are handled.
Wow. Okay. So it really touches every aspect of the hospital experience.
It's designed to be comprehensive.
Now, this document obviously talks a lot about standards. How does NABH actually define that term? What is the standard here?
Good question. So in their framework, a standard is, and I'm quoting loosely here, a statement of expectation. It defines the structures and processes that need to be substantially in place.
Okay, structures and processes.
Yeah, the things that need to be there to enhance the quality of care. So they're the benchmarks.
And when you read through it, you see these codes, like ATC.1. What's that about?
Yeah, the numbering. It's just their organizational system. Those letters, AAC, usually stand for the chapter title in this case, Access, Assessment, and Continuity of Care.
And the point 1 is just the first standard in that chapter.
Exactly. Keeps everything neat and referenceable.
Makes sense. Now, often after a standard, there's something called an interpretation. What are those for?
The interpretations are super helpful, actually. They give guidance on how a hospital can meet the requirements of the standard.
So, like, practical advice.
Kind of. They clarify actions, maybe suggest different ways to do things. And importantly, they distinguish mandatory requirements, things the hospital must do, often using words like shall or should.
The must-haves.
Right. And then there are desirable aspects, using words like can or could, things that are good practice, but...
But they don't count towards the score.
Correct. Only the mandatory bits are assessed during the accreditation process. The desirable stuff is, well, desirable, but not required for the score itself.
Okay, focusing on the essentials for quality and safety. I also noticed some interpretations use words like adequate or appropriate. That feels a bit vague.
Yeah, I see why you'd say that. But it's actually intentional. It acknowledges that healthcare isn't one size fits all.
You mean because hospitals vary so much? Small
Yeah.
clinics versus big tertiary centers?
Exactly. What's appropriate fire safety in a small daycare clinic might look very different from what's needed in a massive multi-specialty hospital.
Ah, I see. So it allows for flexibility depending on the context.
Right. The goal is still quality, but how you achieve it might differ based on the hospital's size, scope, and resources. It needs to be achievable in diverse settings.
Okay, that makes more sense. Now, something that comes up again and again is system documentation. Sounds bureaucratic. Why is this so important?
It might sound like paperwork, but think of it as the hospital's playbook, the recipe book for how things get done.
Okay, a playbook. I like that.
It provides a clear, written framework, ensures consistency, reliability. It means things should be done the right way regardless of which nurse or doctor is on shift.
Right, so everyone's following the same procedure. Standardization.
Exactly. That standardization is absolutely fundamental for quality and safety.
So what kinds of documents are we talking about here? It can't all be the same thing,
No,
surely.
definitely not. NABH breaks it down. First, you have policy documents. These are the really high-level things.
Like the hospital's mission statement, vision.
Yes, exactly. Mission, vision, strategic plans, those enduring policies that guide decision-making across the board, the big picture stuff.
The foundation. Okay, what's next down the pyramid?
Then you have system documentation itself. This layer includes the detailed operational stuff, the quality system docs. This is where you find the standard operating procedures, SOPs.
SOPs. The step-by-step guides for specific tasks.
Precisely. How to admit a patient, how to administer a certain medication, how to handle waste, the real how-to guides.
Got it. And then there are work instructions. How are they different from SOPs?
Work instructions are even more granular, really specific. Think about the exact steps for using a particular piece of complex equipment or one very detailed part of a larger SOP, almost like a checklist for a specific action.
Okay, so policies are broad, SOPs are procedural, work instructions are task-specific, very detailed.
Exactly. We're drilling down.
And to track all this activity, I guess you need forms and formats.
You got it. Templates, checklists, logs. Whether on paper or electronic, they're used to record that something was done and capture the necessary information. Patient assessment forms, consent forms, incident reports.
The evidence that the process was followed.
Right. And some hospitals also formally include externally acquired documents in their system, things like government licenses, legal contracts, manufacturers' manuals for equipment.
Stuff they need but didn't create themselves.
Correct. So, yeah, you can picture it like that pyramid. Broad policies at the top, getting more specific as you go down to the forms and records at the base.
That structure really helps visualize it. Now, you mentioned standard operating procedures. The word standard might make people think these are set in stone, unchangeable.
That's a really common misconception and a crucial point. NABH is clear. Standard here means standardized for the time being.
For the time being.
Yes, these are meant to be living documents. Any hospital with a good quality system reviews and updates them regularly, at least once a year, sometimes more often.
Why so often?
Well, think about it. Best practices evolve, new technology comes along, regulations change. The documentation has to keep up to stay relevant and effective. It's not meant to be carved into stone tablets.
That makes complete sense. Healthcare moves fast. And the standardized formats for forms, why is that bit important?
Consistency. If everyone's recording, say, blood pressure using the same format, it makes the data much more reliable.
And easier to analyze later, to spot trends.
Exactly. You can compare apples to apples. It helps identify issues, track improvements. If information is captured haphazardly, it's much harder to learn from it.
Right. Consistency is key.
Right.
You also briefly mentioned documents of external origin and temporary documents. Just quickly, where do they fit?
External origin docs, like those licenses, the hospital generally can't change them. They just have to comply. Temporary docs are more like informal notes.
Like sticky notes or quick reminders?
Yeah, maybe minutes from a quick huddle, a handwritten reminder. They can be useful day to day, but aren't part of the formal, controlled system that needs version numbers and updates.
Okay, the official versus the informal. The standards also mention using flowcharts.
They do. Flowcharts are a great visual tool. They use standard symbols to map out the steps in a process: start, end, actions, decision points, where documents come in.
Helps people see the whole workflow at a glance.
Exactly. And lots of software makes creating them pretty easy these days. It's another way to make processes clear.
Now, here's a practical challenge I imagine hospitals face. How much documentation is enough? You don't want to drown in paperwork, but you need clarity. What's the guidance?
That's the million-dollar question, isn't it? NABH suggests focusing documentation efforts where consistency is really critical.
Like where?
Especially in areas with higher staff turnover, perhaps. You need to ensure everyone follows the key procedures correctly, even new staff. Also, document things that are specific to that hospital.
Things that aren't just standard medical practice.
Right. If it's a procedure or process unique to their setup or not universally taught in medical or nursing school, then it probably needs documenting. If it's something any qualified professional would know and do consistently, maybe less detailed documentation is needed there.
Focus on the organizational specifics and critical consistency points. That sounds practical. And what about making the documents easy to use? If they're dense and complicated, people won't read them.
Absolutely crucial. NABH highlights a few things. First, have a clear structure, like an index or table of contents, easy navigation.
Makes sense.
Maintain a consistent look and feel layout, fonts, symbols, Maybe use color coding.
Visual consistency helps.
Definitely. And critically, involve the staff who actually do the work in writing the documents.
So they use language that makes sense to them.
Exactly. Use the language the users use. Keep sentences clear, straightforward. Use active voice. Do this, not this should be done. Makes it much more direct and actionable.
Those are great tips. Involving the end users is key.
Yeah.
Now, you mentioned controlled documents earlier. What exactly does that mean, and why is it important?
Okay, so controlled documents includes basically all the formal types we discussed. Policies, SOPs, work instructions, forms, everything except those informal temporary notes.
Got it. And controlled means?
It means they cannot be changed without proper authorization. There's a formal process for updates.
Why is that control so important?
It ensures everyone is using the current approved version, prevents confusion, ensures procedures are followed uniformly based on the latest information. It maintains reliability.
Prevents people from using outdated procedures or making unauthorized changes. Makes sense. What are the hallmarks of a controlled document? What information must it have?
Typically, every controlled document needs a unique name or title, a clear statement of its purpose.
Okay.
It needs to identify the author or the person committee who approved it, and critically, an issue number or version number and the date it was issued or last reviewed.
The version control detail.
Exactly. That creates an audit trail, ensures you always know which version is the current official one.
Good governance. And if you're documenting a specific procedure within one of these controlled documents, is there a standard format for that?
Yes. NABH suggests a pretty standard structure for procedure documentation. You typically include the name of the procedure, its purpose, where it starts and ends.
The scope.
Right. Then the step-by-step instructions, a list of any related records or other documents you might need.
Cross-referencing.
And finally, the authorization details who approved it, their designation, signature maybe, and again, that crucial issue version number and date.
Very thorough. Keeps everything clear and accountable. Now, one more document type you mentioned was manuals, also controlled, but how are they different from, say, an SOP?
Good distinction. Manuals are controlled documents, yes. The key difference is scope. SOPs are usually quite specific for a single department or one activity.
Like hand hygiene SOP.
Perfect example. Whereas a manual often covers broader processes or policies that apply across multiple departments, maybe like an overall infection control manual or a hospital-wide safety manual.
So SOPs are often department level, manuals are more hospital-wide.
Generally, yes. That's a good way to think about it.
Okay, that clarifies the documentation landscape. Now, all these standards, all this paperwork, it's all meant to drive quality. How does NABH actually check if a hospital is meeting these expectations? This is where scoring comes in, right?
Exactly. They don't just tick boxes. They use a scoring system to evaluate how well a hospital meets the objective elements within each standard.
Objective elements. Okay. And these are scored at different levels. I saw terms like commitment, achievement.
Yes. There are 4 main levels they assess against: commitment, achievement, excellence, and core.
Can you break those down? What does commitment mean versus achievement?
Sure. Commitment generally means the hospital has planned the necessary structures and processes. They're maybe in the early stages of putting them in place.
So the intent and initial setup are there.
Right. Achievement means they've gone beyond planning. The processes are actively implemented. They're working. And there's evidence to show it, data, records.
They're actually doing it and can prove it. What about excellence?
Excellence is a more mature stage. It means the processes are well established, consistently delivering good results, and the hospital is showing signs of continuous improvement, maybe even innovating beyond the basic requirements.
Going above and beyond.
And core.
Core objective elements are the absolute must-haves. The non-negotiables considered fundamental for patient safety and basic quality of care. These have to be met.
Okay, so it's like a journey. Commit, achieve, excel, while always meeting the core requirements.
That's a good way to put it. It reflects a maturity model.
Now, accreditation isn't a one-off thing. There's initial accreditation, then surveillance, then reaccreditation. Do the scoring requirements change? They look pretty specific.
They absolutely do. The bar gets higher at each stage.
Yeah.
It's designed to drive ongoing improvement.
Okay, let's take initial accreditation. What does a hospital need to show right out of the gate?
For the first time around, they need an overall compliance score of at least 80% across all the objective elements they score. 80% overall.
Yes. And specifically, at least 80% at the commitment level. They need to show they've got the basics planned and are starting to implement.
Makes sense for the first step. What else?
Every single core objective element must get a score of 4 or higher. Remember, those are the fundamentals.
Non-negotiable. Score 4, is that out of 5? Or?
The scoring for individual objective elements usually goes up to 5.
Right.
So 4 is pretty good compliance.
Okay, so core elements need at least a 4.
Right. And the average score for each individual standard and the average score for each entire chapter must also be 4 or higher.
So consistently good performance across the board, not just hitting the core ones.
Exactly. They also have a limit. No single standard can have more than one objective element scoring less than 2. So no major fails within any standard.
Okay, minimizing weak spots.
And finally, if any objective elements do score 3 or lower, the hospital has to submit an acceptable action plan with timelines for improvement.
Showing they recognize the gaps and plan to fix them. Seems reasonable for initial. Now, what about the first surveillance assessment? What changes?
Okay, surveillance happens after initial accreditation. The overall 80% compliance rate still applies. The 80% at commitment level still applies.
Still need the commitment.
But now they also need to demonstrate at least 80% compliance at the achievement level.
So now they have to prove they're actually doing what they committed to.
Precisely. Show that the processes are implemented and working. That's a key step up.
What else for surveillance?
They also have to show improvement in any objective elements that scored low a 2 or less during the initial assessment. Can't just stay stagnant on weak points.
Driving that improvement cycle.
Exactly. The requirements for core objectives, score 4, average standard score 4, and average chapter score remain the same.
Still need that solid base.
Yes. And the limit of no more than one objective element below 2 in any standard also continues. And, like before, an action plan is needed for any scores of 3 or below.
So the big jump is proving achievement and showing progress on previous weaknesses.
That's the essence of it. It's about demonstrating tangible results.
Okay, final stage. Reaccreditation. This sounds like where the bar is highest.
It is. For reaccreditation, which happens cyclically, you need 80% or higher overall compliance, 80% at commitment, 80% at achievement.
Same as surveillance so far.
And now, also 80% or higher at the excellence level.
Wow. Okay, so demonstrating maturity and continuous improvement across the board.
Yes. The core objectives and the average scores for standards and chapters still need to be 4 or higher.
Consistency remains key.
But here's a significant tightening. For reaccreditation, no individual standard should have any objective element scoring below a 2.
Zero tolerance for scores below 2 anywhere.
Correct. That's a major step up from the initial and surveillance stages, shows a really mature system.
That really pushes hospitals to address all weak areas.
Absolutely. And of course, the requirements for showing improvement on previously low scores and having action plans for scores of 3 or less continue.
So reaccreditation really signifies a high level of sustained performance and ongoing improvement. It's quite a rigorous process over time.
It definitely is. It's designed to ensure that accreditation isn't just a snapshot, but reflects an ongoing commitment to quality.
It's fascinating to see how those requirements build. Now, before we wrap this section, the NABH standards document includes a big glossary at the end. Why is that so important?
Oh, the glossary is crucial. Healthcare, as we know, is full of jargon and specific terminology.
Tell me about it.
The glossary ensures everyone is on the same page. The hospital staff implementing the standards, the NABH assessors evaluating them, even us trying to understand them, we all need common definitions.
So everyone means the same thing when they say adverse event or sentinel event.
Exactly. Clear definitions prevent misunderstandings and ensure the standards are applied consistently.
Are there any terms in that glossary that particularly jump out as highlighting the core focus?
Well, there are many, but some really illustrate the priorities. Terms like adverse drug event and adverse event themselves show the focus on preventing harm.
Right, patient safety.
Antimicrobial stewardship, that's huge now, tackling antibiotic resistance. Appropriate care and best practice point towards using evidence.
Doing what's proven to work.
Exactly. Care plan emphasizes individualized care. Consent, vital for patient rights and autonomy.
Absolutely.
Disaster preparedness, ensuring the hospital can cope with emergencies. Effective communication, so important for safety and the patient experience.
Communication breakdowns are often behind errors.
Sadly, yes.
Yeah.
And then terms like medication error, near miss, root cause analysis, and sentinel event. These all point to a culture of learning from incidents.
Not just blaming, but understanding why things went wrong.
Precisely. Root cause analysis, for example, isn't just about finding out what happened in an error, but digging deep to find the underlying system, issues the why, so you can fix the system and stop it from happening again to someone else. It's like detective work for safety.
That's a great way to put it. That glossary really does sound like a window into the values underpinning these standards.
It absolutely is.
Well, this has been, frankly, a fascinating overview of the NABH standards, the structure, the documentation, the scoring. It's clear how much goes into this framework.
It's a complex system, but it's all aimed at that common goal of quality and safety.
And as we continue our deep dive, we'll be looking at some specific areas, patient care safety protocols, through the lens of these very standards. Outro.
So as we kind of wrap up this first part of our deep dive, I think it's pretty clear that these NABH standards, they provide a really robust framework. It's all aimed at ensuring quality and safety in hospitals.
Absolutely. And that heavy emphasis we discussed on documentation, on having defined processes, and especially on that continuous assessment and improvement cycle, it all builds towards a healthcare experience that should feel safer and more reliable for you, the patient.
Yeah, the goal is definitely reliability and reducing variability.
It's just remarkable how comprehensive it is, touching everything from, your basic rights as a patient all the way through to how the building is managed and how staff are trained.
It really tries to weave quality and safety into the fabric of the entire organization, building that culture.
Now, if you're listening and wondering, okay, but how do hospitals actually track if they're doing well on these things? There's a section worth looking at.
Ah, yes. The key performance indicators, the KPIs. That starts around page 202 in the document, I believe.
Right. And these KPIs, they offer concrete ways hospitals measure their performance against these standards. It's not just about having the process, it's about the results.
Exactly. They provide measurable data, things like the rate of adverse drug reactions or the number of medication errors per 1,000 patient days, real numbers.
Or tracking unplanned returns to the operating theater or maybe to the ICU.
Yeah, or rates of specific hospital-acquired infections like catheter-associated urinary tract infections or ventilator-associated pneumonia. Things you definitely want to keep low.
Patient falls is another one, right? And waiting times in the outpatient department.
Even things like how often informed consent documentation is fully completed before procedures. These indicators give hospitals tangible data to see where they're doing well and where they need to focus improvement efforts.
And connects back to that achievement score we talked about. You need the data to prove you're achieving the desired outcomes.
Precisely. You need to measure, to manage, and improve. These KPIs provide that measurement framework.
It really closes the loop: standards, processes, measurement, improvement. So thinking about everything we've covered, the sheer depth and breadth of these standards, it really makes you think.
It does.
What further questions does this raise for you listening in about how healthcare quality is measured, how it's ensured, and maybe what role do you, as a patient or a family member, play in this whole ongoing pursuit of excellence?
That's a great question to ponder. It's not just a one-way street.
Definitely something to think about. We certainly encourage you to check out the NABH website or other resources if you want to learn more.